Good afternoon, everyone. So at the outset, I would like to thank Dr. Tinku for giving me this wonderful opportunity. So uveitis being a relatively difficult topic. So whenever we are seeing a patient of uveitis, the first thing that comes to our mind is what kind of uveitis am I dealing with? And secondly, what is the best treatment for the disease? We are always worried whether the disease is infective or inflammatory because the treatments are totally opposite. So we know the sun classification, and today we would only be discussing something that happens behind the lens, that is intermediate, posterior, and panuveitis. So intermediate uveitis, a patient would generally come to you, with bilateral involvement in 70 to 80% of the cases, which may actually be asymmetric. And when you look into, you will see some vitreous haze, and inferiorly you can see some snow banking and snowballs, or actually the patient must maybe having only CME with few cells on the anterior vitreous face. So these little signs need to be picked because sometimes the cataract surgeons are in too much hush. They see nuclear sclerosis 2 and 3 and plan a surgery. I think a detailed AC examination and an anterior vitreous face examination is important to pick any cells. Otherwise, post-cataract surgery, you get inflammatory surprise and you wonder why the patient, without any eventful thing in the surgery, is showing so much amount of inflammation. So you should always grade the vitreous haze when you are seeing it in a patient, and this actually is helpful if you are doing a photographic documentation of the same, because when you treat, it is very easy to tell whether the patient is responding or not. But wait a minute, just vitritis doesn't mean intermediate uveitis. So if you're seeing some cells on the anterior vitreous face, there are other diagnoses that need to be considered, which are even more sinister, like acute retinal necrosis, toxoplasmosis, and endogenous endophthalmitis. And the point is that the treatment of these three is totally opposite to that of intermediate uveitis. So in ARN and toxo, which we'll take later, you have a focal retinal lesion, but you have to look for it carefully. And in endogenous endoph, you will have a history where the patient will tell you that he took some intravenous fluids. Treatment of intermediate uveitis, earlier, we used to go oral steroids and then local steroids, and then immunomodulation used to come in the end. But now our tolerance to cataract and glaucoma has really gone down, and we start immunosuppression quite early once we have ruled out infective causes like tuberculosis. So when you're looking at a patient and you see something there, that's the word, there is something, you need to know whether that something is active or healed. That is the first thing that you should aim for. Any active lesion would have a yellowish white border, and vitreous haze may be associated with it, with fuzziness of the borders. While it is healed, the margins get sharp, and there may or may not be a pigmentation. So this differentiation to know is very important, because sometimes if it is just an RPE defect that you are seeing, you can prognosticate and go ahead with your cataract surgeries and everything. But if there is anything cheesy, you see some yellowish thing there, you definitely need to investigate the patient further. The second differentiation is between retinitis and choroiditis, because retinitis would be more superficial. It would be obscuring the underlying vessels. They can be hemorrhage associated. While choroiditis would be more deeper and the margins would be relatively sharper. Why do we need to differentiate? Because retinitis is usually infective, and you need to give specific antimicrobial therapy for that. While in choroiditis, if you have some experience with uveitis, you can go ahead with steroids and immunomodulation. So just touching few diseases, ocular toxoplasmosis, we know that it would be a yellowish white lesion next to a scar. And if it is the first episode, you would see a yellowish white lesion just right at the posterior pole somewhere. Treatment is with cotrimoxazole along with plus minus oral steroids. Acute retinal necrosis, when you would see the periphery, you would see some circumferential pattern of yellowish white necrotizing retinitis, and it's usually in immunocompetent people. And treatment is with valsivir, 1 to 2 grams depending upon the quadrants involved, and with plus minus steroids. Syphilis being the biggest masquerader in eye, anything in eye can be syphilis. So whenever dealing with uveitis of any kind, always get a VDRL or a TPHA done before just progressing with oral steroids or immunosuppression. And the treatment of syphilis is actually very simple. the disease just melts down with benzathine penicillin or with ceftriaxone in case of any hypersensitivity to penicillin. Coming on to CMV, so if it's a typical HIV patient, you would see that brush fire appearance, and you know that, it looks that even if the patient is not diagnosed with HIV. But now sometimes these patients of psoriasis or other organ transplant who are on immunosuppression, like azathioprine, they can actually show CMV retinitis. And usually the form is granular variety where you don't have much hemorrhages. You can also see the frosted branch angiitis variety of CMV, but frosted branch angiitis is just not CMV. There are other diseases also where you can see this. So choroiditis is little subtle and has less specific patterns because it is behind the retina. So the three main patterns there we are going to touch is the infective choroiditis pattern, like the serpiginous one, which is usually associated with ocular tuberculosis, and you see the serpentine pattern with irregular margins. Autofluorescence very well picks up the activity, and the hyperreflectivity you see is active choroiditis. Similarly, choroidal granuloma is also usually infective. And when you do an OCT, this is typical tubercular granuloma where you see the contact sign. The granuloma is actually pressing upon with some neurosensory detachment. These patients usually require ATT along with oral steroids. The non-infected type of choroiditis patterns can be APMPP and mutes. The mutes, this is like the typical wreath pattern that is spoken about, and luckily they are self-limiting, or sometimes you may need oral steroids. Coming on to the non-infectious pattern with systemic disease, the sarcoidosis being the most common. So if you're seeing these depigmented lesions in the inferior retina, you only have two diagnoses in your mind, either it's sarcoid or it is VKH or sympathetic ophthalmia. And then you look for other signs like lupus pernio, or you get a CECT chest done and you see this hilar lymphadenopathy. You know you're dealing with sarcoidosis, and that's how you go about with your treatment. So there are many differentials. Supposedly you see something like that. This is not choroiditis always. A simple thing like CSR with fibrin can also look like choroiditis, and posterior scleritis is also pretty common. So you need to differentiate, and I think here comes the role of angiography, and no other investigation is going to help you with that. Retinal vasculitis, there are multiple reasons. So the main thing is that we should recognize that this is vasculitis. You should see perivascular cuffing with some irregular margins, and you need to note down which vessel is involved. Is it primarily arterial, venous, or both? Is it a skip vasculitis? You can see here where it is not continuous, while sometimes it is a continuous vasculitis. You need to see whether they are hemorrhages, because that's usually associated with occlusive kind of disease. Here, when you do an FA, you see they're completely, we see the capillary non-perfusion areas. And we also need to check systemic things like oral genital ulcers, which are usually associated with Behçet's. So just to mention about Behçet's, we have mobile hypopyon there, and this ferning pattern which we see typically on FFA, and Behçet's require an expert treatment, so we should better hand it over to the expert. The last disease that I'll talk about is VKH, which is the most common cause of panuveitis. It is actually not that rare, and when we see this typical blister-like detachments at the posterior pole, you see it here, and you do an OCT. This is the typical OCT with multiple neurosensory detachments. You should not miss that this is VKH. So we will see hyperreflective dots, happy undulations, multiple neurosensory detachments. When you do an FA, you see the starry sky appearance with late pooling. These multiple pinpoint leaks, that's a starry sky appearance, and this leakage, that's the pooling of the dye in the late frames. In acute phases, there can be different presentations like angle closure, exudative retinal detachment, or only disc edema. So disc edema, if you've ruled out all other causes, VKH is also one of the causes. If not appropriately treated, the patient progresses to chronic stage where we see the sunset glow with the hypopigmented lesions we saw in sarcoidosis. We can see simple RP hyperplasia, and we can have recurrent granulomatous or non-granulomatous inflammation. So how do we stop a patient from going to acute to chronic stage? Only one thing, early immunosuppression. Please do not wait for a second episode of VKH to start your immunosuppression. So I hope I have not complicated things for you, and thank you.
Thank you, Dr. Neha, for making it so concise. It was a very vast topic, I know. So any questions? So
I'll just add a few
Yeah,
points. Very
ma'am.
good presentation, Dr. Neha. About the vitritis part, many a times we see old patients who come with cataract and vitritis. In older individuals, try to rule out mascarides like lymphoma. These patients may have vitreous cells, which are actually lymphoma cells, and even with significant vitritis, they don't have CME. So that is one thing that differentiates from lymphoma from intermediate uveitis. And one more point about sarcoid uveitis, always look for a dry eye, do a Schirmer's test. Dry eye is more common in sarcoidosis compared to TB. Otherwise, it's very difficult to differentiate the two conditions. So this is just one more point. Thank you.
Thank you.
Thank you.